Welcome to Mic'd Up with Chiro Podcast, where I'm your host, Brandon Steele.
And I'm your co-host, Tim Bertelsmann.
And you're tuning into the one and only evidence-based podcast made by chiropractors and for chiropractors.
Here's how it works. We'll have a new clinical topic that we dive into each month, and you'll leave with practical skills that you can apply right away.
Well, that's contingent on who's giving the advice, and you'll want to take mine.
Let's dive in.
Welcome to the next episode of Mic'd Up with Chiro Up. You've got Tim and Brandon today. Unfortunately, we had to bring Tim along for the ride. I tried to do this one all by myself, but he was standing outside waving at me, so I decided to let him in here. I was
just hoping for a little lunch or a drink. I didn't really want to be involved.
This is the last week of Subscriber Appreciation Month. We do this every single year. It's something fun that we get to do to celebrate the individual subscribers, the pieces of feedback, the things that we've learned over the year. So really today's podcast is all about the subscribers we have at Chiro Up. But really, we should do this. They're the reason we exist. They're the reason we stay relevant. They're the reason, I don't want to say forced to innovate, but they push us to innovate, to get uncomfortable with functionality, with ideas, with changes in healthcare, what's happening in chiropractic. So while sometimes you want to stay comfortable, you want to keep on doing what you've been doing for 10 years, change is good. It's also the reason I have 10 times more gray hair than I started with.
Fact checker, you might, you've got 10 times more gray hair, but 10 times less hair. So statistically, it may be more like 100% more.
It's not very nice. Well, you know what? Here's the benefit. In chiropractic, there is no math. So I think we'll just go with that first number.
But there are new research studies. And we're going to be shedding light on a couple of studies about knee pain and hip pain. And most importantly, this blog is going to be tools to engage your patient, including 6 potent strategies to help those patients do their exercises. Before we dive into that, though, just a reminder that if you haven't yet, make sure you hit that follow button to share this episode with a friend. It really does help us reach more great DCs like you.
Before we dive into the meat and potatoes of this podcast, we always like to start off with 2 research articles. These 2 research articles are on knee pain and anterior knee pain, which are sometimes difficult. And the reason anterior knee pain is difficult because it could be the bone, it could be a tendon. If they're young, it could be Osgood-Schlatter, it could be Sinding Larsen-Johansson, it could be knee osteoarthritis, it could be a plica injury. There's so many things that cause anterior knee pain.
I didn't know you knew that many diagnoses.
Oh, I'm just reading it off the script
here.
One of the interesting things about the younger people's diagnosis with knee pain is that issue with that constant stress of that tendon pulling at the bone. And we just gave a talk on pediatric sports injuries, and I never realized how popular that is. Not popular, but unfortunately popular that is with the repetitive stress that our patients are doing to themselves. But today's research study is on osteoarthritis. And what we're finding is that apparently, and I did not know this, osteoarthritis is a mechanical problem. Did you know that?
I need a pen.
Well, when you have a mechanical problem, should you treat it with a mechanical solution or a chemical solution? And what this paper is from Osteoarthritis and Cartilage 2024 says that if you have a patient with a mechanical problem in their knee, like osteoarthritis, maybe injections are not a good choice. In fact, using exercise is better than injections. I would have never guessed that. However, that's the case. Now, as a personal note, or taking the research aside, my favorite go-to exercise for people with osteoarthritis is some type of knee extension with overpressure. You can do with a band, you can do with overpressure from your hand, but I'll tell you what, a lot of these patients have difficulty with extending their knee, and when you can start to regain some of that extension, it really helps them in everyday life, even just getting up from a seated position or walking. Also, to double down on that, I get patients to go through a squatting motion. Now, sometimes you have to use support. In Chiro, we have the double posterior lunge, which will help get a person into that hip hinge maneuver while still being supported, while still being stable. And they're able to now squat, which everybody thinks they can't do, but now they can do, and really take that body weight and strengthen those glutes up. Now, another interesting study that I found on knee pain this year was all about the upstream effects of anterior knee pain or patellofemoral pain syndrome.
The second study, interesting study about FAI, and it said that patients who have knee pain but don't have a structural abnormality in the patellofemoral joint, they don't have a lower limb malalignment issue, do have a higher prevalence of CAM FAI. And remember, FAI has two flavors. Number one is CAM. That means if you're making a fist that represents your femoral head, that head is too long. It's egg-shaped. The second one is pincer. And pincer is if you take your other hand over the top of your fist, representing your socket of the acetabulum, and basically your fingernails would be too long. So your socket is too long, and that's egg-shaped. If either the head or the socket are egg-shaped, it's not a real good ball and socket. And people who have knee pain without problems at the knee tend to have a higher incidence of FAI.
And a lot of people have CAM and pincer deformities. So when that labrum starts to fray, when you have any kind of translation or hypermobility within the hip joint, a lot of bad things happen. So it's an unfortunately mostly an acquired deficit, but some people think it is still developmental. As far as born with it, I don't know. I'm still of the opinion that bad mechanics lead to bad structure. Now, with that being said, we talked about the knee causing hip pain, but the same goes for the ankle pain. And a lot of times people with recurring ankle sprains will have deficits in ankle dorsiflexion, which now will cause anterior knee pain. So the reason I bring that up is just because someone has a CAM deformity, we can treat a lot of things that happen in the hip. Just because someone has ankle problems or knee problems, we can treat those on an isolated mechanism, really take an approach of orthopedically diagnosing and treating it with the right recipes. But once that tissue is calmed down, make sure to look up and downstream because if they have recurring knee pain, take a look at the ankle. Even though they're not having ankle pain, it could be the cause of their problem. So taking a look at the functional diagnosis within chiro will go a long way in patient compliance. Now, why are we here today? Today is all about patient compliance. We really want to make sure that our patients are adherent with their care because it's why they came in to see you. They didn't come in to see you because they like seeing you, because you're a great person. They came in to see you because they have a problem they're looking to solve. So there are 7 of these that we're going to cover today. And the first one is going to be how to prepare a patient. Now that sounds kind of odd. However, the first time I saw Dr. Bertelsmann in practice, I came over here to take a look at his practice, see if it'd be a good fit. It wasn't. However, clinically, there was a little bit of there was a little bit of carryover there.
It's really the first thing you've said on this podcast. It makes a lot of sense.
And he's going to cover 2 things. The first one, extremely important. However, the odd thing is the second thing that he's going to talk about is one of the coolest things that I ever saw in practice that I instantly gravitated towards. And even though he's a subpar chiropractor, he's very good at the second part, so you don't want to miss this one.
We all have to have skills. The first part is the making the patient comfortable. When they come into your office, you have to realize that they can be very apprehensive. That how many of your patients each year tell you, yeah, I've got this lower back pain that hurts when I lean back and forward. Do you think it's bone cancer too? That patients don't know what's happening, they don't know what's going to happen in the office, that they're scared for all different reasons. So putting them at ease, one thing that we do is an initial visit tour. When the patient comes in, making sure that they understand who is the staff, that I'm Becky, I'm going to be able to help you do this, and taking them through the office before you drag them right back to the treatment room. Let them see your therapy area. Let them know that this is the area where we treat other things too, like rotator cuffs and plantar fasciitis. Making sure that they see the treatment room, and here's a specialized table that the doctor is going to use to provide gentle treatment to your whatever condition they're having. And that if they get a flavor for that and they get to see that you treat other things, you're moving them in the right direction. And then I think one of the other things that really helps out is after the patient has told you their OPP-QRST in the consult, is repeating that back to them. That when the patient hears, okay, Mary, let me get this straight. What you've told me is that you have this lower back pain. It gets worse when you stand or go into extension. It's local. It doesn't radiate into your legs. It feels a little bit better when you do some home exercises. It tends to increase throughout the day, but you're very stiff in the morning. You'd rate it as an 8. You have no abdominal pain, doesn't cause any bowel or bladder dysfunction. Is there anything that I missed? And so the patients are blown away by that process. You're just telling them what you expect to hear for that diagnosis or the differentials that you have in your mind, but they're blown away that you remembered. You're probably the first doctor who's truly remembered, and repeating it back is a potent tool that will pay many, many referrals in the future. One thing that we've done recently to really ramp this up is now we send out our chief complaint survey to collect that OPPQRST before the patient ever gets to the office. So when they come into my treatment room, I already have most of that information there and I can review it with them. It's taken our consults from 20 minutes down to 2, 3, 4, 5 minutes. There are no marathon consults anymore, and it's made my job a whole lot easier.
I forgot the research study, but it's in my talk on the rotator cuff that the number one thing that determines the future success of treating someone with shoulder pain is, does the provider listen and care about their problem? And that is very, very true. While I listen, I care usually, but there is a certain part of empathy that goes into that. Is truly putting yourself in the patient's situation. Like, okay, Sally can't do X, Y, and Z because of this problem. Not only do I need to recognize it, but I need to get Sally back to her life. And I think that kind of merges right into the next section, which is defining roles right off the bat. There are so many people that come into my office that want me to fix their problem. And while I do have a responsibility to help them out, they also have a responsibility in care, but also in responsibility for what caused their problem to begin with. So the thing I want to talk about is defining roles, because I think this is a big piece that's sometimes missed in chiropractic practice. And when someone comes in with a problem, I need to tell them what I'm responsible for. Listen, Sally, you have an SI joint dysfunction. My responsibility in this is to get things loose. My thing is manipulation. I'm going to use manipulation. I'm going to use manual therapy. I'm going to use exercise. I'm going to use these modalities. Whatever it may be, tell them what they're going to expect each time they come in to see you. And then tell them what they're responsible for. Listen, Sally, if I get things loose, I need you to keep things loose. So I need you to be doing these exercises. I need you to avoid these activities of daily living. I need you to stop sleeping in this way. I need you to stop standing for 10 hours a day. What are the things that they're responsible for that probably caused the problem to begin with? And then finally, what are the time expectations? Because every tissue takes time to heal. That unless you're, some specialized product on Amazon that fixes everything, there are no miracles performed in a chiropractic practice. So we have to make sure that once we get that orthopedic diagnosis, whatever it may be, let's say it's, we just did a webinar on plantar fasciosis. Listen, if you have plantar fasciosis, is that going to get better in 24 hours? No. That's okay. The patient isn't expecting a miracle, but they are expecting a realistic expectation of how long it is going to take. And remember, your treatment plan should mimic that diagnosis. If you have someone with SI joint dysfunction, someone with BPPV, someone with a cervicogenic headache, those are actually very short time frame diagnoses. So that's good. That's good for you. It's good for the patient. Everybody's happy. But if someone has a long-term diagnosis, lumbar spine stenosis, they have lateral epicondylosis been going on for a long period of time, this is going to take a little bit of time. Once again, that's okay as long as you tell the patient up front this is going to take a little bit of time, a month, 6 weeks before you start to see progress and alleviation of symptoms. They'll go along the ride with you as long as you set a very clear plan of what to do and what you're going to be responsible for. And then also don't forget to co-treat, meaning if someone needs more help, they need to see a massage therapist, they need to see a functional medicine doctor, they need to see a psychologist sometimes. Those are all things or people you need to have in your back pocket to say, listen, I'm going to do X, Y, and Z, but I think at this point you can probably also see another provider that's going to help along with this treatment plan to solve this problem a little faster.
Yeah, really, that's all part of the recipe. I remember a couple of years ago, one of my friends had come in, and when I grabbed him, he's a PCP, and he said, "You know what? You guys have a really easy job." He said, "You're kind of like Taco Bell." And I said, "What are you talking about?" And he said, "You have 5 or 6 different ingredients in your recipe. You have manipulation, you have exercise, you have modalities, you have ADL advice, you have some soft tissue, stretches, myofascial release. And you just blend those into a different recipe for different conditions." He said, "It doesn't matter what I send you, you're going to do similar things." And I thought, that's true. He said, "My job's really hard that I've got these 2 huge PDRs that I have to look through thousands of different medications and a Merck manual that I have to be aware of thousands of different conditions." And he said, "You've got, 100 conditions that show up regularly." Well, in reality, he's got 20 that show up regularly too. But he's right that we do have a relatively easy job, but it's not easy because we know there's a a huge difference between treating someone and truly applying a best practice, and those things change. I think back to how ChiroUp started, and it was because we had a failed patient, me. I wasn't the patient, but I was the failure. And the patient came in with shoulder impingement. She didn't show up on the 4th visit, so I asked the front desk, where is she? And they said, she's not coming back. She's going to go see her doctor because she didn't improve with care. And that stings. So we decided to dive deeper and say, well, what can we do differently? And we came up with a protocol. We learned about a couple of things a decade ago, and those emerging things were scapular dyskinesis.
First off, I already knew about scapular dyskinesis.
That's good. If you'd have shared it, it would have helped me a lot of time because I've been pretty busy the past decade. And we also learned about tendinopathy, that concept was emerging at that point in time. That things are not an itis. It's not an inflammation. If it's there chronically, yes, you can inflame your rotator cuff tendon, but if it's been there for 6 months, it's no longer inflamed. In fact, it's de-inflamed. And all of our treatments had changed from what we were doing that wasn't working to trying suppressing inflammation to now trying to generate a controlled inflammatory reaction, with all of the treatments now being IASTM or shockwave therapy or laser. None of those suppress inflammation. Dry needling, they generate controlled inflammation. So once we had that recipe, we were onto something, and that's how it grew from there, and realizing that those recipes changed, that the recipe 15 years ago didn't look anything like what the recipe looks like today. So having a resource that can keep you up to date with regard to those aspects too.
Yeah, I didn't know where you were going with the Taco Bell story. However, one cool thing about that is we do MD meetings. So about maybe twice a month, Ben and I are out, and we talk with different primary care doctors about co-managing cases and that kind of stuff. And there's always a lack of, I don't want to say humility, but I'm going to say humility, sometimes with some providers that really think that they can treat everything. And that doesn't go just primary care doctors. It goes across chiropractors and massage therapists, that whenever anybody walks in their door, they think they can fix them. But one thing I will say is that being a primary care doctor is probably very, very difficult. I don't even understand all the things they have to know or understand. But what does, sometimes when a patient comes to me after a primary care doctor and it fails, they think that medicine failed them or the anti-inflammatory failed them, and that, well, that didn't work. That's actually a good thing, because that tells us it's not a chemical problem. It's probably more of a mechanical problem. And so I relay that to my patient. Listen, whatever that Dr. Smith did, it wasn't wrong. It just wasn't right for you. So never, put anyone else down, and instead say, you know what, that didn't work, but let's find a solution for you. And I think that leads very well into one of the next things that we're going to talk about, is that patients need to understand what you do in your clinic and what you don't do in your clinic. Because not all chiropractors, not all medical doctors, not all massage therapists do the same thing. So making sure you have a very clear mission of what you do in your clinic. And one thing we don't do is perform miracles. That a lot of times patients have unrealistic expectations. Let's imagine this patient, and as soon as I bring up this story, I'm sure you're going to remember this patient. This is the patient that you haven't seen in a while, and they come in on Friday, and on Friday they come in because they've had lower back pain. This lower back pain has been going on for 2 months. It's raging. It's going down their leg, and they're leaving for Disney World tomorrow, and they want you to get rid of their pain now. You can even name that person because you've had that patient. So I think that unfortunately patients have unrealistic expectations. They think there's going to be some kind of miracle or something we can do or some bone we can put in place that's going to fix their problem. And it's very important to say that, listen, I can identify your problem and I can put you on a path to help you with your problem, but we are a partner in your care. We don't perform miracles. Unless you're copper fit and can fix everything, we can't do that. So making sure that we get the right diagnosis and give them realistic expectations, we'll let them know kind of what we do. And if you recognize this is something that probably isn't a good thing for you to treat, refer them on. Those are the patients that are probably the most loyal when you say, listen, I'm sorry, I know your diagnosis, but this is something that I'm not able to fix. Or I don't want to. Maybe I'm not the best person to fit that. I go twice a month, I'm out giving lectures on shoulder pain. However, I don't treat frozen shoulder. And it's not because I'm not able to. It doesn't mean I can't do it. I'm not educated enough. I said, those people take a long time to get out of pain. And they don't fit well into my practice style, so I refer them to a local PT, or we have an associate chiropractor that I refer to because they don't fit well into what I want to accomplish in practice. So it doesn't mean that we can't do it, just some people just don't fit well in your practice. Now, before we cover the last 4 strategies, a word from our sponsor, because I hear this company is doing good things.
All right, so this is Dr. Todd Whitehead. You run a successful practice in Amarillo, Texas, right?
I do.
And you've been with us since 2019. How many providers do you have in your office?
3 doctors,
And lots of staff that helps you run ChiroUp, right?
a lot of staff. Everybody is well versed on it too.
Okay, fantastic. So if you can, in a couple of minutes, just tell us how ChiroUp has enhanced your practice.
Prior to ChiroUp, it was a lot of manual labor trying to get home exercises started, making copies. Everybody had, different books that we would make copies out of, and writing things out, and, just the typical, very difficult system.
Handouts and
I met you guys
follow.
I met you guys at a conference, and I was like, what is this? I was like, and immediately, the platform is so good. When you look at it, you're like, well, there's nothing else in the market that deals with us for sure that is as easy. It's almost like looking at an iPhone. It's just very intuitive. So I was intrigued, and then we started using it right away. And obviously, once you start using it, you're like, well, you're doing for your patients what you should be doing anyway, but you're doing it more consistently with less work. So I think that was probably the number one thing that it did for us, is that it allowed us to do evidence-based exercise instruction and really communicate with our patients about their conditions and what was going on very rapidly. And also, I think the biggest selling point is that I tell patients, I'm like, look, you don't need to go to the internet, because whatever these guys have built into this program is as current as the science gets. So if I'm giving it to you, it's good.
That's it.
We don't need to go look somewhere else. Some guru doesn't know better. I'm just telling you, this is the best. And I think the patients go, oh, cool. And it makes that just much easier for us every single day. Yeah.
That's fantastic. What kind of feedback do you get from your patients then?
About like all patients, right? Like, do I have to do these? I'm like, how often, are you looking at the app every single time that no, I memorize my exercises. And I'm like, well, how do you know if I didn't change your exercise like yesterday?
Right.
So they're always trying to outthink you, right? And, so using the app and, what was the Becky? I'm so sorry. What was
that's okay. No worries. I was just going to say, what kind of feedback have you gotten from your patients that actually use the app?
Yeah, and the feedback is excellent. I think there's a survey that they send back, right, and it's how they're improving, which I think is really interesting, and it's very good for our record too. And across the board, they're all, they have these really high user rates and these really high outcome numbers with doing this stuff at home. So it's really enhanced what we do every day.
Awesome. And staff can get on board pretty easily. It's got a short learning curve.
Super simple. Like I said, it's very intuitive. It's just things are where they're supposed to be. There's not a lot of buttons. It's super, super simple. And the cool thing that I noticed that you guys keep doing is it keeps getting better. It keeps getting easier, right? Yeah. And it just evolves the more everybody uses it.
Yeah. So one last question I'll ask you. Do you ever foresee not using ChiroUp in your practice?
No. And I tell everybody, I'm like, this is like the biggest no-brainer. This is the easy bill that you pay every month, because it really is a partner with you, and it makes you money, and it makes your job a lot easier. So I don't see the downside to it at all.
That's awesome. That's why I picked you, Dr. Whitehead. I could have said that was going to be your quote, the no-brainer. You always say that every time you bring anybody over to the booth. It's always, this is the no-brainer. This is what you need in the office.
Yeah. So that's all we're all looking for, right?
Right. Exactly.
We got to have somebody help us, right?
Yeah.
There's a lot to do. So
there is a lot to do. Thanks for joining us, Dr. Whitehead, and giving us your thoughts on using ChiroUp. We appreciate you being a member for so long.
So glad to be here. Thanks, Becky.
Wow, that's cool. I think I'm going to sign up for that. That sounds like something I could use.
Give me your credit card. I can sign you up right now.
Okay, I'll get right to that. Number 5, tools to improve awareness of what you treat. So you've had a patient, they come in, you've seen them for their neck or their back pain or their headaches, and they come in 6 months later and say, I had to skip some visits because I had to go see a PT for my shoulder or my tennis elbow. You're like, why didn't they know that I treat tennis elbow or rotator cuff problems? So we use a couple of tools to help mitigate that. Number 1 is that we have waiting room videos. So these are any area where a patient might sit for a period of time. We have a video monitor. Now they're $100 to get a huge monitor. We stick a memory stick inside of it that has a downloadable video. And this video talks about lots of different conditions, the 20 most common conditions that you and I treat. It also has good ADL advice as far as here's how you should set up your workstation. This is what you should think about when buying new athletic shoes. This is how often you should change your shoes. All sorts of things that keep patients engaged. So rather than scrolling junk media on their phone with all sorts of ads that you probably don't want them seeing anyway, they're getting your infotainment. And it is entertainment as well. We have jokes, we have stories, we have quotes, motivational things. And the good news is we have produced a version of this for you that during Subscriber Appreciation Month, all subscribers can download our engagement toolkit. And you can download this onto a memory stick, put it in that monitor, and that will mitigate some of the patients not knowing what you treat. We also keep a rack card display in any area that patients are sitting. And this has about 16 of the most common conditions that we treat, carpal tunnel syndrome, but also things like sports injuries. So we have rack cards. They're customizable. If you ever want them branded to your clinic, let us know. We can do that, and we're happy to do that for our subscribers. But it just lets them know that you treat more than what they're in there for.
It's also important to get online reviews. Unfortunately or fortunately, it depends on how you look at it, 79% of people trust online feedback just as much as a personal recommendation. This is big, so there are a lot of chiropractors who don't do a lot of stuff online as far as Facebook and Instagram and have a website, but there are people that have problems that are interviewing potential solutions online every single day. And the question is, are they interviewing you? And if you don't have a presence online, they're going to interview the person down the street. The other thing is that within Chiro, make sure that if you have a happy patient, someone comes in and says, hey, everything's going great, send them that one-time Google review link. If you go in their patient profile and just click on send review, you're able to do that. It instantly goes to their phone. It texts them a link to rate you online, and now they can do it right there in your office. Or you can do it in an automated fashion with any kind of condition report that you send out. It is sent out a 30-day survey, and a part of that is a Google review. That is how we get a constant 3, 4, 5 Google reviews per month. Keeps our site high as far as website ranking.
Yeah, I'm just thinking if only I could have had an online review for you before we started this whole thing. That would have been handy. That unfortunately or fortunately, our patients and our businesses do have online reviews. And everybody has their own online review, and that's our social media pages as well. So 2 billion active users per month on social media platforms. Instagram is one of the big ones. On an Instagram video, you don't want that to be more than a minute. It's just a quick clip about them. And one idea for that is if you treat carpal tunnel syndrome, just print out a condition report for carpal tunnel and basically read it on Instagram. Obviously don't read it, but memorize it. Read it and say, hey, if you have numbness and tingling in your first 3.5 digits, it could be carpal tunnel syndrome. The good news is research shows that chiropractic care works really well for that. If you'd like to learn more, call my office. I'd be happy to talk to you. That's all that it takes to make a great Instagram post about your office. For our patients who might be over the age of 40-ish, Facebook is probably a better platform to reach them. It's still quite alive, and you need to let them know that your practice is still quite alive. That social media content is the equivalent of driving past a restaurant when you're on vacation and seeing how many cars are in the parking lot. If you see a bunch of cars, you know it's probably a good restaurant. If you see no cars, you don't stop there. And that's what patients do on our social media pages as well. And finally, make sure that your website is alive also. A blog that has current information. If you have some videos about conditions you treat or information about conditions you treat, patients are going there with a problem. Your website needs to mention that problem.
I think one of the things that will build a practice no matter what is having your patients understand your purpose in practice. That I think that every person and then every business needs to have a why. And obviously we all know of Simon Sinek, and he was one of the headline speakers at Vegas, and I had the chance to listen to him. I also have gone through his books, and one of the things about the why in a personal and professional realm is to think about these three things. That your why must be resilient. It has to withstand cultural and technological and political change. I mean, it needs to be a lifelong thing. It needs to be inclusive, meaning what you'll know about your patients, what you'll know about your friends and family, is that these people believe in what you believe. And if they don't do that, then they're probably going to find someone else or some other business to believe in what they believe. And the last is service-oriented. Never is this more true in chiropractic, as us being in business, the benefit cannot be for us. It needs to be for the patient. So when a patient comes in to see us, it's not to pad our stats and to line our pockets. Our why cannot be self-serving. Our why has to be directed to the patient to help them.
Yeah, absolutely. Patients see your unspoken motives and they vote with their feet. So we need to make sure that our goals are in line with their goals. So finally, number 7 is talking about what do we do to get patients to become more of an active participant in their recovery through their exercises. And I think first we need to make sure they understand the importance of that. I always think back when we had one of our top providers in the system. So we see the outcomes only for the top 3 providers for each diagnosis. We have a provider who's one of the top providers for 5 different diagnoses, which is just unbelievable. So we went out to his clinic and took a look, and as I was there, I was realizing he does pretty much the same things that we do. Why are his outcomes better? And on the way home, it struck me, and it's because this provider did a much better job at explaining why the patient needs to do what he's asking them to do. He had a patient who had a forward head posture and said, hey, you know what? You're like a bowling ball that's hanging off the edge of a table. If I asked you to hold this there all day long, your arm would get really tired. So you need to pull that bowling ball back up on top of the table, and the only way that happens is through doing your exercises. So until you start doing that, you can expect to continue to feel poorly. The patient understood what's happening. So we need to identify not just the diagnosis, but what's the functional deficit that's perpetuating that, and how do we make the patient understand that functional deficit is part of the root of their problem. And then choosing a motivator that matters to them. That if a patient is frustrated because they can't participate in a specific ADL, then give them a little dose of FOMO about what a pain-free life with that ADL may look like. If a patient is looking really just to improve their performance, let them know that every Olympic and MLB and NFL team has a chiropractor on staff, and it's because small percents of improvement matter, and for them it could be big percents. And patients who are motivated by time or money, let them know that doing their home exercises is going to save them time and money.
Yeah, and really, the rehab part of this is providing a simple solution, is that there has to be a better way to go about life. And if we can do simple, attainable goals, create some small action steps for these patients, we can really make a dramatic difference if they do that on a daily basis. I love the book Atomic Habits, and it talks about habit stacking. So if you want someone to do exercise 3 times a day, make sure you stack it to a habit. So every time you eat, do you do these exercises? Also take into consideration with any kind of exercise selection, avoid the terrible twos. Too many and too difficult. Too many is, listen, you can't have patients doing a half an hour of exercise every single hour. It's just too much. Now, the same for too difficult. That, sweet, Grandma Gertrude, who's 97, is probably not going to do the Copenhagen adductor stretch. She's probably not doing, Roman deadlifts. So we need to make sure that we keep people doing what they're, they need to do, and just bring them one step closer to, glute strength or arm strength or whatever it may be. Making sure that we keep in consideration that we really should strive for quality over quantity, and making sure that they're able to do the exercises, because the best exercise is the one a patient is able to do and willing to do.
That's potent advice. And remembering that too difficult is relative to the patient. That's something that seems very simple for us. A knee to chest exercise might not be that simple to the patient. When you give a patient a little bit more of a complex exercise like a TFL stretch, you can tell if they tried it because they're going to ask you the next day, how do you do that again? When they're in your office, that may not be the best learning environment. They're still probably a little bit concerned or apprehensive, and they're not in the mode where they're trying and practicing it necessarily. We need to give them supportive material. So when they go home, they have pictures, they have videos so that they know exactly how to do that. And they need to know that somebody cares, that you're going to be checking up on them tell them to use their HealthCom app, tell them to let you know how their discomfort was, and then you can see their exercise compliance and letting them know that tomorrow when you come in or next week when you come in, we're going to see if you had any concerns, and I'm going to be checking your compliance. If they know somebody's watching, they want to please you, they want to get better, and it's that added motivation to get them moving along. One of the things is to make sure that we let them know that they're going to be getting those exercises. So we use a poster in the office and a postcard letting them know what to expect along the way. And one of the things that we're including in our patient engagement toolkit is a new patient expectations graphic. And this basically says, here are the things that I expect from you and the things that you can expect from me. And certainly expecting from them is doing their homework.
And setting realistic expectations and goals, and just letting the patient know this is going to take a little bit of time. One thing that I think about with nutritional goals is that for a patient to get healthy, it doesn't happen overnight. If you go from eating McDonald's cheeseburgers to broccoli, you're not healthy tomorrow. In fact, it takes about 4 weeks to implement a change, just to get that habit down. It takes another 4 weeks when it comes to nutrition before you start to notice a difference. So 8 weeks into that change, and then another 4 weeks before other people notice a difference. So making sure your patients understand that any change in habit, any change in nutrition is going to take a little bit of time. In fact, just getting stronger, it takes 4 to 6 weeks to increase your strength. So it doesn't happen overnight. It doesn't mean you're going to be a bodybuilder, but we need to start these changes as far as rehab now for the future benefit.
We also need to address those patients' barriers, that everybody has some sort of barriers, whether it be a lack of time or not fitting into their routine, or maybe they have some psychological barriers. And one of those common psychological barriers is not understanding the difference between hurt and harm. That patients need to know that there's going to be some level of discomfort that accompanies any new exercise, especially if you've prescribed it well. So letting your patients know that mild or even moderate discomfort up to a 3 or a 4 is okay and beneficial, and they should work through that soreness. Now, if they have sharp reproduction of pain, if they have peripheralization of their symptoms or reproduction of numbness, tingling, or neurologic signs, they need to back off those. But otherwise, they need to nudge discomfort on a daily basis.
And then provide that feedback, because there's so many people that come in, oh yeah, that hurt me, so I stopped doing it last week. Well, wait a minute. We need to make sure that they understand that it's going to cause some discomfort, especially if we're starting to strengthen muscle. I think the one thing that will also help patients with their accountability is to make sure they know that you're checking HealthCom. That sense of accountability is going to be a potent tool for most patients to understand that, hey, my provider cares. He or she wants me to get better, and it's going to be very helpful when they know that you're taking a second look at that. Also, realize that progression is key. So we don't need to start everyone off with running 7 miles and doing 50 burpees. That maybe starting someone off with a simple clam and then adding resistance will help get someone on that path to achieving those goals. And HealthCom will do that with phase 1 and phase 2 exercises.
Well, we hope this information has been helpful for you to help engage your patients, to make them active participants in their recovery, to help you improve your outcomes. And recognizing these are stories from one clinic that's been running for the past few decades. There are lots of other ways. We would love to hear your feedback and your input. Feel free to email us, tim@chiroup.com or brandon@chiroup.com. Post on our social media platforms. We're not Tim and Brandon. We are a network of 3,000 providers throughout the world who have an audacious mission, and that's to make our profession the undeniable best choice for patients and payers, and we're proud to be on that journey with you.
If you haven't already, make sure you follow Mic'd Up with Chiro podcast wherever you're listening. Leave us a review. We'd love to hear your biggest takeaway from this episode. I have to say that we pre-planned the first 6 of these. And then after that, every podcast you've heard since that has been the direct feedback of one of the listeners. Hey, I want to hear more about ribs. I want to hear more about cervical radiculopathy. What do you think about X, Y, or Z? So your feedback significantly tailors what we do in the future. So if you have a suggestion, please send that to brandon@chiroup.com. If it's really complex and difficult, send it to tim@chiroup.com. Thanks for listening.
Hey, thanks for listening. To access more information, visit chiroup.com. You can sign up for a 14-day trial. Use referral code podcast15 for a special discount after your trial. Offer valid on new subscriptions only.